Welcome to our cutting-edge online point-of-care ultrasound fellowship program. We are excited to invite you to this pioneering fellowship designed to empower healthcare professionals with advanced skills in acute care ultrasound. As a participant, you join a diverse global community committed to transforming patient care through innovative ultrasound practices in critical and emergency settings. Our comprehensive fellowship is meticulously structured into 2 immersive modules, each spanning 24 weeks. Whether you're just beginning your ultrasound journey or you're a senior clinician refining your expertise, this program is tailored for you. Our curriculum bridges the gap between theory and practice, providing an evidence-based, clinically relevant approach to ultrasound education. You'll explore critical applications, including shock volume assessment, cardiac function, and sonoanatomy, lung normality and abnormality pathology, several acute care procedural guidance, several real-life practical case scenarios, and much more. We understand the demands of your profession, which is why our fellowship offers unmatched flexibility. All interactive sessions are recorded and available on a user-friendly learning platform, allowing you to revisit key insights anytime, anywhere. Through expert-led lectures, real-world case discussions, and journal clubs, you'll gain a profound understanding of ultrasound applications, backed by the latest evidence. Our esteemed faculty consists of renowned experts dedicated to guiding and mentoring you throughout your journey. With their support, you'll enhance your skills and stay at the forefront of ultrasound innovation. By the end of this fellowship, you won't just master ultrasound techniques, you'll become part of a global network of like-minded professionals, fostering collaborations, knowledge exchange, and continuous learning in acute care ultrasound.
Thank you very much. Bismillah ar-Rahman ar-Rahim. It's my great honor and pleasure to welcome you all to this new version of our series of webinars, which we started them on February this year when we conducted the first webinar. The webinars which we planned to have to put the faculties in direct contact with people working in acute care settings. And we bring everyone working in the acute care setting the importance of this science and this part of critical medicine and emergency medicine. The second webinar, which was on April, followed by the third one, which was conducted on May, and this is the fourth. We are very delighted and proud to have 2 eminent speakers for tonight. The first one is Professor Dr. Xavier Monnier from France, and Xavier will speak about one of the important topics of daily questions in ICU, which is about when to give fluid, how to predict the fluid responsiveness in mechanically ventilated patients, echo rule. And the second eminent speaker is one of the known doctors and professors in Canada, Dr. Muhammad Abbasi. And Dr. Abbasi will speak about the pre-hospital care using POCUS in trauma victim. I'm very proud, again, to co-share this webinar with Professor Michel Slama from France, who has some delay in joining us because of some constraints in Paris. And I'm very proud to have Dr. Muhammad Nasruddin, consultant of emergency medicine in Riyadh, to co-share this session with me and Michel Slama. The program for tonight, as you see here in this slide, is going to start soon by the lecture from Xavier Monet, as I mentioned. And will be around 20 plus minutes, followed by another 25 minutes or plus minus with Dr. Abbasi. And then I will give POCUS program update, important messages. The important messages before we launch the online fellowship program. And then at the end, we're gonna direct your questions, me, Nasruddin, and Michelle Islama, to the two speakers. And I will be here for answering any question related to the program, to the online fellowship program. Without any further delay, I'm very happy to introduce the first speaker of tonight, who is, as I said, Xavier Monet. He's a friend of mine, and he's a professor of intensive care medicine with a lot of work on hemodynamics. Everyone knows him, and particularly in use of point-of-care ultrasound in hemodynamics. As I mentioned, Dr. Xavier Monet will speak to us tonight about how we use the point-of-care ultrasound to predict the fluid responsiveness in mechanically ventilated patients. So please, we start the lecture with Xavier Monet.
Hello, I'm Xavier Monet. I work in medical intensive care unit in Paris, and we will see today together how we can predict fluid responsiveness with echocardiography. And I first disclose the following conflicts of interest, especially with companies that develop some cardiac output monitoring devices. In fact, we can speak about this by taking a very practical example. That's a patient with a respiratory distress and hypertension entering the emergency department and then the ICU. And this patient has a very low blood pressure. Of course, you diagnose septic shock, and of course, your first treatment will be the infusion of a fluid bolus. Okay, but why? That's the first question. Why do we give fluid boluses? Why do we resuscitate our patients with fluid? You will all agree with me that we expect from fluid that it will significantly increase the right and left cardiac preload, that it will result in a significant improvement in stroke volume and then oxygen delivery, that it will result in tissue perfusion improvement, increase in cell oxygenation, and finally a decrease in anaerobic metabolism. In this cascade, the first step that is limiting is the increase in stroke volume. Usually, half a liter of fluid significantly increase the mean systemic pressure, the right and the left cardiac preload. But this does not always increase stroke volume. Indeed. What is the relationship, the physiological relationship between cardiac preload and stroke volume? That's the cardiac function curve, well described by Frank and Starling, and we are more used to look at this relationship on that way. The more you increase cardiac preloads, the more stroke volume and cardiac output increase, but it's not a linear relationship. It's curvilinear. And the slope, by the way, depends on the cardiac contractility. First, where we give a fluid bolus, we expect that cardiac preload increases and that stroke volume and cardiac output will increase. It means that first, the first effect of a fluid bolus is not to increase blood pressure. It is to increase stroke volume and then usually cardiac output because heart rate doesn't change significantly. However, a number of studies have shown that this increase in cardiac output following the infusion of a fluid bolus, typically of 500 milliliters of fluid, do not always increase cardiac output. It even increases cardiac output in only half of the cases. And the main reason why is likely the different slopes we have for this Frank-Starling relationship. It may happen that you give fluids that it increases preload, but because of the flat slope of the Frank-Starling relationship, the increase in cardiac output is negligible or at least not significant. At the same time, it may be a problem to give fluid to non-responsive patients. I mean non-responsive in terms of cardiac output, because in such a case, you would give fluid without any benefit and only with some deleterious effects and fluid accumulation. It means that very practically we are facing two problems. First, the effect of a fluid infusion are not constant, and second, fluid infusion may be harmful. And logically, the consequence is that one should predict fluid responsiveness before deciding to give a fluid bolus. Okay, let's test fluid responsiveness. Then, of course, the next question is, okay, but how do we do that? How can we assess or predict fluid responsiveness? And especially for our topic today, how is it possible to do that with cardiac ultrasound? In fact, it's quite easy. The easy way to test preload responsiveness is to use a dynamic way, a dynamic method. I mean, let's change cardiac preload in any way, spontaneously with the ventilator or any maneuver you want, and look at the change, the resulting change in stroke volume and cardiac output. And if stroke volume and or cardiac output change above a critical thresholds that will depend on the test you use, then you may say to yourself, my patient is likely fluid responsive. I may consider fluid infusion with a reasonable trust that cardiac output will indeed increase. With cardiac echo, I know 5 ways that can be used to assess preload responsiveness. Some mimic a fluid challenge, and some others use Hartland interactions. What is first this mini fluid challenge? It consists in infusing not the whole bag of fluids, the 500 milliliters typically, but only a small part of it, typically 100, 150 milliliters. And if you observe a significant increase in stroke volume, so it means a significant increase in VTI, in LVVTI with echo, then you may consider giving the rest of the fluid bolus. That's quite well, so it's a quite reliable test. We have a reasonable amount of studies. The diagnostic threshold is not that well defined. Let's say that an increase in VTI larger than 5% is likely correct, but it may be smaller. It's quite easy to perform, I mean, just to infuse part of the fluid bolus, but there are some limitations. The right way to do so may be first to measure the LVVTI, then to infuse fluid rapidly, typically with 3 syringes of 15 milliliters, and then assess VTI again. Very importantly, the same people may stay at the bedside with a probe on the patient measuring the LVVTI all along the maneuver. Why? Because one of the limitation and the main limitation of this mini fluid challenge is that it requires a very precise measurement of stroke volume, of VTI. Because indeed, this small amount of fluid can only induce small changes in VTI. And you see the diagnostic threshold is only 5%. But VTI is not a very precise measurement. In this study, we showed that if you make a measurement, go out of the room, of the bedroom, come back and do the measurement again, the smallest change you may consider is only 10%. On the contrary, if you keep your hand on the patient and while you do the two measurements, but keeping the probe exactly at the same side, at the same place, the smallest change that becomes detectable by echo is 4%. So very practically, keep the probe on the patient when doing a mini fluid challenge with echo while someone else infuses the 3 syringes of 50 milliliters. Passive leg raising is, of course, another way to mimic a fluid challenge. As you may know, when you move a patient to the passive leg raised position, you transfer roughly 300 milliliters of blood toward the cardiac cavities. It's very highly variable from one patient to another, which come from the legs and from the splanchnic compartment. We have a very high level of evidence that this test is reliable. As you may know, it's been included in many recommendations, including the Surviving Sepsis campaign. So the test is reliable, and that's been demonstrated by a lot of studies. The increase in cardiac outputs you may look for, and so in VTI with echo is a 10% increase. And in such a way, you see that the sensitivity is high and the specificity is high as well. As I told you, it's including today in the recommendations of the SSC guidelines, in these upcoming ESICM guidelines on circulatory shock and hemodynamic monitoring. We also recommend using dynamic variables of static variables of preload for testing preload responsiveness, and we recommend the passive leg raising as a sort of reference for testing preload responsiveness. So that's very well established. We may have a problem in some patients with intra-abdominal hypertension, which may create some false negatives. And the other limitation is it's not that easy to perform. For the same reason as before, I strongly recommend that the same person performs echocardiography and keeps the probe on the patient while somebody else moves the bed without taking the heels of the patients and the legs of the patients, but rather by using the automated motion of the electric bed before you measure VTI again when the patient's been back to the semi-recumbent position. Another way to assess preload responsiveness is the respiratory variation of the maximal velocity of the LV outflow tract. It's not that much used, you will see why. The principle is this one: at each insufflation in a ventilated patient, cardiac preload decreases, which means that if stroke volume and typically the amplitude of the Doppler flow in the LV outflow tract does not change a lot with ventilation, it means that the patient is preload unresponsive. On the contrary, if stroke volume varies a lot from during the respiratory cycle, it may indicate preload responsiveness. That's typically the principle of pulse pressure variation. And by the way, if you have an arterial line, this pulse pressure variation is automatically calculated by the bedside monitor, and nothing is easier for testing preload responsiveness. If you have no arterial line, if you just have echo, then you may measure the respiratory variability of the maximal velocity of the aortic flow. And then the diagnostic threshold may be a 15% change in this maximal velocity. The reliability is not that well demonstrated, and especially it's particularly difficult in practice in a mechanically ventilated patient to keep the sampling window of the pulsed Doppler exactly at the same place in the LV outflow tract while the patient is breathing. And of course, if you do not move the probe with the patient's breath, then you may see variations in the flow that may not be due to preload responsiveness, but just to the fact that the echo beam goes out and in compared to your echo beam. And so that's why it's quite difficult to perform. So in practice, my patient is ventilated. Again, you should follow the respiratory motions by moving the probe during ventilation, measure maximal and minimum LVOT or maximal velocity of the LV outflow tract. This shares the same limitations as pulse pressure variations, of course. Don't use it in patients with arrhythmia, with spontaneous breathing because of false positives, and in patients with ARDS. And so in a large majority of the patients, in any way, you will not be able to use this different test of preload responsiveness. Many of you who do echo may have a look at the IVC, the inferior vena cava, especially for assessing its respiratory change. Bear in mind that this is the least reliable way we have to assess preload responsiveness. It has been demonstrated by a lot of small studies and their meta-analysis. It has been demonstrated by a large negative study, more than 500 patients, the ability of the IVC, inferior vena cava changes, to assess preload responsiveness was only 0.65. The area under the RAC curve was very low. It was just a bit better with the superior vena cava, but you need transesophageal echo. It's more difficult. And in any way, the predictive ability is still not very good. Why so poor results? Likely because it's not a pure marker of preload responsiveness. Did you think about why? The IVC changes its diameter in case of preload responsiveness. That's not that obvious. Of course, in case of preload responsiveness, the intramural pressure, the CVP, changes more than in case of preload responsiveness, but obviously that's also influenced by many factors like the vein compliance, the intra-abdominal pressure. I mean, it's not a pure marker of preload responsiveness. In addition, many people miss the fact that you cannot use the respiratory variation of IVC or SVC in case of spontaneous breathing, in case of low tidal volume, and in addition, in case of intra-abdominal hypertension. The final way to assess preload responsiveness using the ventilator with cardiac ultrasound is the respiratory occlusions. In fact, the principle is quite easy to understand, as you now know. In a ventilated patient, each insufflation tends to decrease venous return, decreases cardiac preload, because you inflate air around the lungs, so preload decreases. And so, for instance, if you stop ventilation at end expiration for a few seconds, it means that cardiac preload will increase. And if you wait a quite long time, more than 10 seconds, it has the time to cross the pulmonary circulation. And eventually, if cardiac output increases, it means that both ventricles are preload responsive. This is the principle of the end expiratory occlusion test that we have described with Jean-Louis Deboul years ago. It's very reliable. We have a number of studies. That's one of the meta-analyses. We performed more than 5% increase in cardiac output is a threshold value. With cardiac ultrasounds, that's more problematic because 5%, as you've heard, is below the smallest change you can detect with a cardiography. That's why we suggested that if you use echo to assess this test, you performed not only 15-second and expiratory occlusion that should increase stroke volume in VTI in preload responders, but add a few seconds later An inspiratory hold that will, on the contrary, decrease stroke volume in prelude responders and add both changes, the absolute value of both changes. And we showed that if you add both changes, the predictability, the area under the RUC curve here is very good, and the threshold for positivity is 15%, which is compatible with the precision of echocardiography. So that's not that easy. It means that first you measure VTI during ventilation. You take a mean value of VTI, stop ventilation at the PEEP level for 15 seconds, measure the highest VTI value. For instance, it's 22 centimeters. Start ventilation again, then stop it during the end inspiratory hold. And typically, if the decrease in VTI is from 20 to 18 centimeters, it means that in total, VTI has changed by 20% larger than the diagnostic threshold. Not that easy to perform, but quite easy to use because these are just respiratory holds. However, some patients are not able to tolerate these quite long respiratory holds, 15 seconds. 15 seconds, that's quite long. And so some people, some patients interrupt the respiratory hold while you're still pushing on the button. And in such cases, the patients are not sedated, etc. You cannot perform the test. And then it's the big advantage of having different tests, and some, as you have seen, reliable ways and quite easy ways to test prelude responsiveness with the ventilator. So to conclude, if you followed me well, I think that the three ways we have to use cardiac ultrasound, it means if you have no other way to assess cardiac output for testing prelude responsiveness, are the mini fluid challenge with this problem of precision, passive leg raising, the best established test, and respiratory holds, not that easy to perform, but quite reliable. Thank you very much for your attention.
And from here, we will go for our second speaker for today, Dr. Mohammed Al-Abbasi. Dr. Mohammed Al-Abbasi is a assistant professor of emergency medicine at Northern Ontario School of Medicine, Canada. In addition to his wide expertise in the field of emergency medicine, Dr. Abbasi had a special interest in point-of-care ultrasound, being one of the master instructors at the Canadian Point-of-Care Ultrasound Society. Over the next few minutes, Dr. Abbasi will give us a short brief about the use of point-of-care in the pre-hospital field in trauma patients. Dr. Abbasi, please, the mic is yours.
Assalamu alaikum. Good evening, everyone. My name is Mohammed Abbasi. I'm an emergency medicine assistant professor at Northern Ontario School of Medicine in Canada. It's my pleasure to be today with you all in this prestigious fellowship. Thanks, Dr. Nas, for the nice introduction, and thanks, Dr. Ashraf, for allowing me to share with you this topic. So today we will spend some time together discussing the point-of-care use, point-of-care ultrasound use in pre-hospital trauma victim. So when you think about you are a doctor in EMS and you are going to the field, or you are an EMS crew and going to manage motor vehicle collision. So what's the use of point-of-care ultrasound? Any background, any evidence of ultrasound use in the pre-hospital settings? To be honest, there are many studies done in the pre-hospital fields, critical care medicine, and trauma settings to highlight the importance of use of ultrasound in the pre-hospital settings. So imagine you are going to manage this multiple trauma patients in MVC. What approach you are going to use using the point-of-care ultrasound? I believe we should go using the ATLS approach, which is ABCDE approach. So let's see if we are going to manage the airway, breathing, circulation, and now we can go to start with extreme bleeding or catastrophic bleeding control. So we'll go through some cases to see how the ultrasound will help us to manage those patients. So our first case is a 23 years old male patient, came on MVC. He's hemodynamically unstable with signs of catastrophic bleeding. You started your initial resuscitation and the patient didn't respond, and you suspect this patient is having catastrophic bleeding. So you decide to go for REPOA. So what's REPOA? It's resuscitative intravascular balloon occlusive of the aorta. Its main indication is to manage traumatic torso hemorrhage and life-threatening bleeding below the diaphragm. Your main aim is to control that catastrophic bleeding by stopping the flow into the aorta at proximal to the bleeding site. So of course you are going to use the point-of-care ultrasound through insertion of a catheter through the right femoral and go for catheter insertion according to the zone you are going to manage, if it's zone 1, zone 3, according to the suspected bleeding site to control that hemorrhage. So we manage that catastrophic bleeding and we will go our journey through the ABCD approach with our second case, 51 years old male patient on MVC. He was unresponsive and having signs of impending airway compromise. So you decide to intubate this patient. How ultrasound will help us to intubate this patient or manage this patient airway? Actually, we have many things that we can do with ultrasound in that pre-hospital settings. First of all, let's see quick anatomy. So for airway anatomy, you can go and scan the patient using longitudinal or transverse approach. Here you can see on this view, the brown thing here you can see is the hyoid shadow, and the purple thing you can see is the thyroid cartilage. And when you examine here, you can see at the vocal cord level. So this patient, we decide to examine the anatomy while preparing for intubation to see if the patient might require surgical airway. So here with a longitudinal approach, as you can see here, the green is representing the thyroid. Here you can see the cricoid, and here you can go for the cricothyroid membrane. Down here you can see the tracheal ring. So this patient, if we fail to intubate the patient and we decide to go for cricothyroidotomy, we highlight the anatomy, we landmark the anatomy, and especially in difficult situations like big neck, disturbed anatomy, then we are going to do our cricothyroidotomy using ultrasound. So this patient, we decide to intubate. How ultrasound can help us to confirm the intubation. So as you can see here, the trachea, if we intubate the patient, you should see that you're going through the trachea. And at baseline, we cannot see the esophagus. So there are many studies that highlighted the importance of point-of-care ultrasound use in verification of endotracheal tube placement. Many systematic review, meta-analysis, according to the ACLS guidelines in 2015, they added point-of-care ultrasound as adjunct to confirm ET tube placement. So let's see this patient. We decide to intubate, as you can see here. I wonder if you can see my cursor. Good. So you can see here the tracheal ring, and while we intubating, you can see some reverberation artifact with the tube going through the trachea. On the opposite, if we intubate the esophagus, which is common in the pre-hospital settings, so you can see here a double trachea or double bullet sign. Here you can see the difference between intubating the trachea only or intubating the esophagus, where you can see double bullet sign here. So with intubating the trachea, you can see the reverberation artifact, a bullet sign. You don't see the esophagus, while if you intubate the esophagus, you would see double ring sign. So we intubated this patient, and after intubation, we discovered that the patient is still hypoxic despite the tube in place, and we confirmed endotracheal intubation. So we decide to use the ultrasound to do to go for assessment for his breathing. So we decide to examine his lung, and as you can see here, we started to examine the right lung, and while scanning the right lung, you can see nice lung sliding, shimmering effect, A-lines. So unlikely this patient is having pneumothorax on the right side, but we want to scan his left lung to see if this patient is having right main stem intubation or pneumothorax. Here you can see no lung sliding. So our differential diagnosis here is either this patient in hurry, we intubated the right main stem bronchus and pushed the tube further in. We can withdraw the tube and check and rescan again, or we can scan other multiple levels to see if this patient is having different thing, like here. Here you can see this patient is having lung point, which is pathognomonic for pneumothorax. So this patient is having pneumothorax on the left side. So here we decided to put chest drain into the left lung. So we decided to scan the right lung more and go for different side. And sorry. And while we're scanning the patient, we can see here spine sign. We can see the liver, large pleural effusion, and collapsed lung. So instead of inserting chest tube on the left side, we now put double chest tube for managing pneumothorax on the left and right hemothorax. So we'll continue our journey with another case of 25 years old male patient who fell from 10 feet. He's complaining of abdominal pain. His blood pressure is 110/80. Heart rate is 98. To some extent, the patient is hemodynamically stable. So we decide to do the fast examination. So we started with right upper quadrant. As you can see here, liver, kidney, nice clean interface. And here is the importance of swiping technique. So as you can see, with one view only, you cannot see any free fluid, but here while you swipe, you can see a clear rim of free fluid. So what's the next step in management? This patient is hemodynamically stable. We can see free fluid in the abdomen. So we arrange for CT if the patient is hemodynamically stable. So CT was arranged and showed grade 3 liver laceration and intra-abdominal free fluid. So patient was shifted to OR immediately. Here's the importance of ultrasound use in the pre-hospital settings. For example, in my city here, we are tertiary care hospital. We do have some specialty, but we don't have all the specialty. So if the patient is in a remote area, like 1 hour, 2 hours away from our site, and the EMS, instead of bringing the patient to a local hospital or local emergency that doesn't have any local resources, no OR or no trauma surgeon. So if they scan that patient and decide that the patient is maybe he's still hemodynamically stable, but he's having free fluid in the abdomen. So he needs bigger level of care. It's better to transfer him to a larger trauma center and get the best care possible. So let's continue with our next case. A 49 years old male patient with blunt chest wall trauma. Here at the scene, he's complaining of chest pain. His blood pressure is 80/50 and heart rate of 70. So we decide to look at the heart. This is apical four-chamber view. And as you can see here, patient is having large pericardial effusion. There's RV collapse, good LV function. Here's another view with subxiphoid view. As you can see, large pericardial effusion, trampoline heart, which is highly suggestive for pericardial tamponade. So this patient was diagnosed with pericardial tamponade, and patient was stabilized after pericardiocentesis, will be transferred to definitive care to a facility with cardiothoracic surgery. So let's continue with our circulation assessment. 65 years old male patient was involved in MVC. He's complaining of abdominal pain. On clinical exam, you can see the patient is having peritoneal signs, seatbelt sign. He's mildly hypotensive on clinical exam. And any evidence of use point-of-care ultrasound in managing hemodynamically unstable patients or shock patients. So there are many, many studies to suggest many protocols, starting from EFAST to diagnose free fluid in the abdomen, and to the management, like fluid resuscitation, how to check for cardiac output, response for resuscitation, false protocol, rush protocol, and sorry, and starting with EFAST for this patient. So we decide to scan his abdomen again. As you can see, we can see free fluid at the moisten pouch. And while examining this patient epigastrium, we found this. So what we can see here, some might say I can see nothing. I can see some maybe A lines, but this is not the lung. Actually, this is free air under diaphragm. As you can see here multiple A lines that represent presence of air inside the abdominal cavity. So ultrasound is much higher sensitivity and specificity compared to X-ray for bowel perforated viscous. To be honest, X-ray sensitivity is about 78%, ultrasound up to 92%. The specificity is almost similar, around 53%, but positive predictive value is nearly 95% for ultrasound. As you expect, this patient was found to have perforated viscous, taken to OR, and managed. Our next case is a 22 years old male patient with a gunshot to the chest. EMS found that patient is unresponsive and pulseless. So how ultrasound can help us in managing those situations? And we know it's a stressful situation. Patient is pulseless. The scene is chaotic. And sometimes when you start to feel the pulse, you cannot find the pulse. The patient is not showing any signs of life. But is pulse check with our hands is always accurate? Is it easy? In such situations, even in the emergency department controlled environment, sometimes it's chaotic. Some patients might have very weak pulse. You can detect with your hand. So you decide to go for the ultrasound to check. There are many studies, including this study of use of point-of-care ultrasound to compare the pulse detection by palpation compared to the point-of-care ultrasound, and found that it's easy to use, easy to train people how to use it, and you can get best results. You don't get much interruption to the CPR if it's ongoing, with high degree of reliability and sensitivity. So this patient, we confirmed he's in a cardiac arrest. Would ultrasound help us managing this patient, beside that the patient might have reversible cause like precardial tamponade or pneumothorax to detect some other reversible causes? Yes, of course, we can see, but also it's a good predictor of the patient's prognosis. Does this patient will go into risk, will be neurologically intact after having this cardiac arrest? It's quite different between each countries. Some countries like the States or UK, EMS can terminate the code after 20 minutes of non-shockable rhythm. Maybe 15-22% patients arrive to the emergency department. It's a bit different in other areas of the world, including here in Canada. Some EMS start managing those patients for like 45 minutes, 1 hour, with the patient is in asystole or chokeable rhythm. I have the privilege to work with two professors who wrote this patient, both Tim Harris and Steve Thomas, while I was working in the Gulf region. So they found that managing the patient with point-of-care ultrasound at the bedside to diagnose cardiac arrest, if the patient, among all the studies in that systematic review and meta-analysis, no single patients who have non-shockable rhythm, no cardiac activity, and no pericardial effusion uh, found to survive. Only one patient who survived to the emergency department, but after that, he had lost in the emergency department, but he died at the hospital. And this is some area of debate. What kind of cardiac activity do we look at when we manage cardiac arrest, or especially traumatic cardiac arrest? Are we looking for any activity? I believe we should, despite of that may be a big debate, we should go for meaningful cardiac activity. At least we should see good LV contraction that's able to produce some cardiac output, or opening the aortic valve and produce some cardiac output. But only like flickering or small valve movement, I wouldn't consider this as meaningful cardiac activity. And this patient, according to your local protocol, if it's after maybe 20 minutes or 30 minutes, you can declare this patient dead. Personally, I had similar case of a 20 something years old came in after 45 minutes or maybe 50 minutes of continuous CPR. And when he arrived to the emergency, we put the probe, no cardiac activity at all. And we ended the code immediately. So we are going through our journey. We check for the airway, breathing, circulation. Then how about disability? So our next case is a 46 years old male patient with blunt head injury and low GCS. Due to facial edema, we couldn't assess his pupil reactivity. And the patient start to have abnormal posture, and we think that the patient might have high ICP. While preparing for intubation, protecting the airway, and um, doing some intervention to control possible high ICP, we decide to scan this patient. So One of the nice things in trauma settings or even in non-trauma settings is to measure the optic nerve sheath diameter to detect the high ICP. So how to do it? We go to measure. We scan the eye. We scan the back of the eye. We aim for the optic nerve 3 millimeter behind the retina, both in transverse and sagittal, in the most distensible and reproducible area. We measure inner side to inner side and aiming to check the diameter of the optic nerve. Again, there are many studies, systematic review, meta-analysis that looked at what kind of dimensions aiming to, what cutoff we should use. There is a big debate because it's vary from children, adults. Most of the studies recommend some range between 4.8 millimeter to 6 millimeter cutoff point. Around 5 millimeter sensitivity may be 75 up to 100% with the specificity approaches to 100%. If you found the optic nerve sheath diameter is more than 5.8, the sensitivity go higher, 90 to 100%, which is very good in the pre-hospital settings. So our next case, now we go from assessment of airway, breathing, circulation, disability. How about exposure or extremity, or using point-of-care ultrasound, we can go extra. Can we manage anything else related to trauma? This is an 88 years old female patient with left forearm pain, swelling after fall on outstretched hand. The patient is a known case of metastatic cancer. She lives at the hospice. Comfort care, she is DNR, and the family requested limited in-house care. So any rule for point-of-care ultrasound to diagnose this patient? You suspect this patient might have Colles fracture or distal radius fracture. Point-of-care ultrasound in managing or diagnosing musculoskeletal injuries have lots of evidence now in diagnosing, managing shoulder dislocation, distal radius fracture, fracture, especially in kids, while you minimize the exposure. And many studies suggest that the ultrasound is maybe around 98 sensitive and 96 specific in managing or diagnosing distal radius fracture. And the positive predictive value approaches 98% and negative predictive value approaches 96%. In this paper specifically, they suggest 8-step POCUS assessment to diagnose distal radius fracture. As you can see here, you can see the cortex and you can see step off and angulation. How ultrasound can help us? Basically, you can diagnose, as in this patient, you can detect that the patient is having distal radius fracture with some displacement, angulation. And then at the scene, this patient, you are not going to transfer at the hospital. If you want to splint on site or maybe put the patient in a cast while doing reduction, will not go, of course, of conscious sedation. Even in a measured department, you can get failed conscious sedation, failed attempts. So you decide to go for this patient and do hematoma block using ultrasound. So you get the area of the hematoma, you put your needle and local anesthetic, then do hematoma block, put the reduction, and after reduction, you are not get an X-ray post-reduction. You put the patient in a cast, and before that, you check the position, make sure that you at least reach a good alignment. So let's summarize. So point-of-care ultrasound is really helpful tool that you can use, starting from managing catastrophic bleeding using RIBOA, managing airway with diagnosing getting the correct airway anatomy, help in confirmation of endotracheal tube placement, breathing, scanning the lungs. You are aiming to check for pneumothorax, pleural effusions, and confirmation of endotracheal tube placement if it's on the right main stem bronchus intubation. In circulation, you have lots and lots to do. You can go to check for cardiac arrest, any possible cardiac arrest causes, pericardial tamponade, aiming for even central line, peripheral line insertion using ultrasound. Nowadays, there are some studies how to confirm IO access, patient with difficult access, and you decide to put interosseous line, how to confirm that with a flushing using power Doppler to detect the flow inside the bone marrow. Then in disability, you can check pupillary action while the patient eyes is closed because of the edema. You can check the pupils. You can detect optic nerve sheath diameter. If you have more experience, you can go for transcranial Doppler and diagnose any bleed and the circle of Wells. And exposure, many studies now recommend use of point-of-care ultrasound to diagnose fractures, dislocation, and managing post-reduction. So to conclude, ultrasound is a very useful tool that you can use either in EMS settings, pre-hospital settings, and emergency department. Nowadays, it's not necessarily to be done by emergency physician or critical care physician. Now you can depend on EMS. There are many courses and programs to help EMS to integrate their management instead of just transferring the patient to the hospital. No, we can stop, diagnose, and do some interventions. And with AI now, you can, as a physician, you can be on your site, guiding the EMS crew or the transport physician on site, how to use the point-of-care ultrasound in diagnosing and treating such conditions. Thank you, everyone. I enjoyed my time, and I will wait for your questions.
Thank you very much, Dr. Muhammad Abbasi. I really enjoyed the presentation. We can say it from A to Z in pre-hospital management of trauma victim. Really, really nice presentation. And as well as the presentation of Dr. Xavier Monet was also great. So without further delay, let me go to this third part of this tonight webinar, and then we will move to the Q&A right after that. I hope you see my slides, Dr. Nasruddin. Okay, very glad that we have big number of attendees tonight. We reached more than 470. And as I said, we enjoyed two very, very informative, very nice presentations. And the presentations like this highlights more and more on the importance of the point-of-care ultrasound in every acute care setting. And we try with these free webinars to establish a statement which is already established, which is there is no excuse of having point-of-care ultrasonography exam for any acutely ill patients, whatever their presentation is. And tell me where you are, I tell you where is gonna be or could be the point-of-care ultrasound to help in reaching the diagnosis and tailoring the management plan. There is no doubt on this. There is no doubt on this in the real life scenarios, which we see every day in acute care. There is no doubt on this and strong evidence from the literature point of view. Despite we have some controversies about the use of this or that, but the point which has to be very clear is the decisive point in here is how you do the point of care ultrasound is going to reflect the result of this study. If you know how to do, and you know when you have to have point of care ultrasound exam, and you know how to do it, then the result will be positive, positive in diagnosis and positive in management plan. And this takes me to why we thought of the point of care ultrasound in acute care setting, not only in critical care, not only in emergency, but in any acute care setting. And we called it like this, point of care ultrasound in acute care setting online fellowship program. Despite it's online, but we have a lot of things to make it very interactive and very practical as well, as much as it can be as an online activity. But it's not only online. I'm going to come to this, but just to remind you that the program, which is Common Pathway Program, basic part of the online fellowship program, will cover the whole things related to the basic knowledge of point of care ultrasound. And then we take you to another 24 weeks of advanced pathway. Either you choose to go to the pathway of emergency or to go to the pathway of critical care medicine, and both of them are very valuable to anyone, even if not working in ICU or not working in emergency, like the primary care, like medicine, like surgery. Everyone has to have the basic and some advanced knowledge of point of care ultrasonography. And what makes this program very unique, that it's very selective in the common pathway and very selective in the advanced pathway. Selection was made to make things very clear. What you need bedside, we're going to teach you how to do it and what is the evidence behind this. We have this program designed, collaborated under the umbrella of WICCEM, the World Institute of Critical Care and Emergency Medicine, with joining academic participation from both Sun School and Saving Lives Academy, two of the academies, two of the bodies that has tremendous activities in point of care ultrasonography in the field. And we designed the fellowship to be materials that is loaded to a platform designed for the candidate. And I'm going to come to show you how this will work. In this platform, you're going to find weeks from week 1 until week 24. Week 23 and 24 will be the exit exam of each module, basic module and advanced module. So you have 22 weeks of materials. And every week, the candidate, the fellow, will see lecture, which is recorded by one of the faculties. We have well-known, esteemed faculties from all over the world in both critical care medicine and emergency. And the lecture will be followed by 10 questions to answer, to test if you, as a candidate, understood this lecture very well or not. And then you go to the next part, which is a journal club. We select a recent paper for you on the same topic you read, you answer question on. And then we're gonna have the third and last part, which is clinical case scenario. Let's say, for example, clinical case scenario of pneumothorax, how you see it, how's the point of care ultrasonography will handle this case for you to reach diagnosis and to manage. And then every 4 weeks, we're gonna meet the faculties, the program director, the 2 academic directors, with the fellows online, live, on a webinar like this, to discuss the previous weeks, to bring us the cases, and we interact with you as a group discussion to reach what can we learn from the shared case or we'll bring you our experience and we'll discuss it with you as a fellow. As I said, every 2 weeks of each module is going to be left for exam. You're going to have two chances to set the exam, 2 weeks to set the exam, which is going to cover the whole module. You have to achieve 60% of the mark to be graduated from this module. As I said, it's a well-designed platform made by expert in IT, in ICOM company, doing great job so far with other programs already finished, like the critical care nephrology. And this platform is going to be very easy, friendly to use. It's not only, as I said, a one-man show that you sit in front of the computer and you study the material and that's it. No. You're going to have the right in every week as a fellow registered with us to call for a meeting with the faculty or to call for a meeting with the program director, who's I am, or one of the academic directors. All of us will be for you and every week and anytime you need something to be clarified. This has to be planned, of course, at least 2 or 3 days before the date you wish to meet us, and we arrange a meeting for you. It's not only that, but also in the live webinar, which is going to be every 4 weeks, as I said, you bring your cases and we'll discuss it with you. Again, it's not only that, but also we decided as a scientific committee to give you two choices. Either you choose to go for the online part of the fellowship only, and then we're going to give you at the end of the module, if you take the basic only, or the 2 modules, if you go with the advanced only, attended only the online, we'll give you the testimonial certificate that you attended this fellowship, and we're going to monitor your assignments and your success in doing the weeks. We're going to monitor you thoroughly through the weeks of the program. Or you take the other way, another choice, which is you decide to take diploma, not only fellowship online, but diploma, then you have to show us that you have in-person or physical attendance of one of the hands-on courses that is widely distributed and present from any of the known societies, like Sunu School courses, Saving Lives Academy courses, SCCM courses, or any one of the recognized courses. And you're going to be requested, and this is the last and very unique part of the fellowship program which we offer, that you upload 50 cases at least of your own cases, and we mentor you, supervise you in these cases, and we see if you did the exam right, you interpreted the images rightly, and you integrated what you find in the management plan rightly or not. So you attended online, you attended one of the courses, or just one course, and you attended or you uploaded 50 cases with mentor that we select for you or you select and we agreed on. If you do this, you're gonna be awarded a diploma in point-of-care ultrasonography. I'm coming to the accreditation now. And I'm gonna assure you that the accreditation is gonna be at least we are preparing to be at your expectation. There are certain important dates you have to notice. June 30 is decided to be the start date since we thought of this program. Since December 2024, we decided to start on June 30. The first week will start on Monday, June 30. We decided because the first week is a heavy week, it's full of physics, 2 lectures, 2 journal clubs. So we decided to give this week 2 weeks for the candidate to finish, not only because of the heavy week, but also because of some hassles we might expect on registration, on the reach of username and password, and so on. Some logistics difficulties that we may face. So we give the first week 2 weeks. So you start June 30, Monday, early morning, 12, midnight, 12. The June 30, you start the first week, and will be ended by Sunday midnight, July 13. So the second week, which will be covering fast, will be starting July 14th. And will be ended by 21 or 21st of July, and so on. So mark your agenda on these dates, because I receive a lot of communications to us when the program is going to start. And every time on every webinar, we say that we're going to start June 30. And in every announcement, we say June 30. So again, I'm saying it, June 30 is the start, inshallah. The discount of 25% for group of 10 is still valid. But unfortunately, the discount of 15% decided by the organizing committee of the program to be ended since May 31st. But for the attendees of this webinar, we opened another coupon or code for the attendees of this program to be used for only 10% discount. And this is, unfortunately, again, will end after 48 hours. There are grants. I'm going to come to this. As I said, the accreditation is already with AACME 96 hours. We are in the process, and we promised to have the ESICM EDIC accreditation of this program. We had it already before for the master class, which we're already running it for the third or fourth year now, the critical care ultrasonography master class with Dr. Walid Al-Habashi in Saving Lives Academy, already accredited by EDIC as one of the recognized and the only course in the Middle East. We developed big trust with the ASICM. We have a strong link with the American Society of Critical Care Medicine. We opened the link with the Canadian societies as well. We are working with ESICM. We promise to work on the pathway for the American Society and for the Canadian if we can. What we already had is AACME. What we already promised to have a channel to open it with ESICM, and we are planning to open with American Society and Canadian if possible. Ladies and gentlemen, let me take you to important online important sites that everyone has to see, which is the WICCEM homepage. Once you click on, you're gonna see a lot of fellowships here. And if you choose to go, I hope you see my arrow and you see my screen, Dr. Muhammad Nasr. If you confirm, you go and choose the fellowship Point-of-Care Ultrasound, as you see here. You're gonna see a side here, the webinars or recorded webinar. The previous 3 webinars are recorded on the site here and free for anyone to visit. And then you can go through the web page to see the promo video, to see how.
Dr. Ashraf, would you please expand the window of the website?
Sorry?
Would you please expand the window for the website, because it appears only the title, but the whole window doesn't appear.
Now, is it clear? Do you see the pictures of the faculties? Oh, no, this is not the let me try again here. So you go to the fellows, you choose the Point-of-Care Ultrasound. It opens for you the landing page of the Point-of-Care Ultrasonography. What I want you to see here.
We can see it.
Yeah, it's opening. You can see. It's opening. Sometimes the glitches from the internet speed. Anyway, you see the varieties of faculties from all over the world, from Europe, from Canada, from America, and from Egypt, from Saudi Arabia, from Lebanon, from Turkey, everywhere. Here, you're gonna see that we have already paid 78 doctors, and we granted scholarship with big discounts, reaching up to 75% discount for the candidate comes from the low-income countries. We are not for profit, ladies and gentlemen, but there are expenses that have to be paid. The grants will be given to those who fulfill the criteria. Just visit the landing page and see. We have candidates from 18 countries so far, from Latin America, from Africa, from Europe, from Middle East, from Egypt. 18 plus countries are with us. When you visit the landing page, you will see full detailed program. As you see here, PDF, you just open it like this, and then you can go through logistics of the weeks, who is gonna teach you in every week and what you're gonna be taught in these weeks. The objectives of every week are very clear here. As I said, you may see also the scientific, the program director, the academic directors, and any details you wish to see about the faculties, as I mentioned, from all over the world. With a link with big societies, we are proud of this group of faculties, all without naming them details. Again and again, do not forget, if you are from low-income countries, to apply for grants. It's available here because we're receiving Q&A, a lot of questions about this. Just go visit this site, this landing page, and click on register now, apply for grants if you see yourself entitled for this. 2 weeks before the program start, so almost on 16th or 17th of June, plus minus, you will receive email if you are registered fellow, giving you the username and password to go the platform designed for you. I'll give you an example of how this works. Here, this is my name as instructor. But what you're gonna see here is as well the if you
Cannot
click
see your screen, Dr. Ashraf.
you don't see the screen. Let me try again here. We're taking time because this is very, very important logistics that we have to be aware of. Do you see it now?
No, we can see
With just the browser title, the browser URL at the top, but the whole image of the website doesn't appear. I think you can try sharing the whole screen, Dr. Ashraf.
Again. Yeah, okay. Is it showing now or not yet?
Yes. For the website link, it's already shared many times.
For the sake of the time, we can do this in our orientation meeting next week.
Okay, we can do this. Let me try one more time here. Hopefully you started to see it now. So anyway, what I wanted to say and what wanted to show you here is that I designed the platform for only the fellows will be, the username and password will be sent personally to you, and you will be able to go and access the weeks, the different weeks, week after the other, and you fulfill and you do your assignment on this matter. I will stop here. Thank you very much. This is the updates I wanted to share with you. Bottom line, the start date is June 30. Week 1 will be ended by July 13, not 1 week only. It's going to be covered in 2 weeks. and the username and password will be sent to you very soon, at least 2 weeks before the start date. Grants are given to low-income countries. Please take the advantage of another 10% for the attendees of this online fellowship, online webinar that ends in 48 hours. Thank you very much, Dr. Nasruddin. We can go to the Q&A now.
Thank you, Dr. Ashraf, for your great clarification for the program. As you clarified, many already asked questions regarding the program schedule and starting date and grants. I think all of these questions have already been answered. So one of the questions was to Dr. Abbasi. It's about the use of point of care in assessment of retroperitoneal bleeding. How could be helpful? How could it be helpful for assessment of retroperitoneal bleeding if so?
Actually, still the gold standard for retroperitoneal bleeding is the CT scan. There's some protocols, some case reports. Personally, I diagnosed 1 or 2 retroperitoneal bleed with the point-of-care ultrasound, but still on a large scale, it's still not the best test. Go for CT scan if you are suspecting retroperitoneal bleed.
Yes. Every test has its own limitations. It's not like 100% sure. One fit for everything. Dr. Ashraf?
Sorry, say again?
I'm saying that every test has its own limitation. So the ultrasound still has its own limitation in that point for retroperitoneal bleeding, as Dr. Abbasi clarified. However, another one for Dr. Abbasi, it's about the optic nerve. So asking how to assess for the optic nerve. She's the internet.
So let me share my screen. Can you see my screen?
Yes, clearly.
Okay, good. So we are aiming to scan the optic nerve, scan the eye. Preferably, if you can, scan the right eye and the left eye, aiming in longitudinal and in transverse, aiming to see the retina, and that black shadow here is the optic nerve. You are aiming to measure 3 millimeter behind the retina from inside wall to the inside wall of the optic nerve. Because there are different literatures suggesting different numbers, so it's the best is to compare the patient to his own eye, the right eye. So if the left eye is 3.5 millimeter and on the left one it's 5, so you know that there is the diameter of the optic nerve sheath is dilated on this one. So aiming for 3 millimeter behind the retina at the back of the eye, then you measure from the inside to the inside of the optic nerve. Hope this helps.
Yes, and as Prof. Javiz couldn't make it to be with us today, I would like to redirect these questions for you, Dr. Ashraf.
Go ahead.
They are asking about the effect of vascular tone and the meaning of vasopressor use of vasoplasia in sepsis, and how could that affect the precise use of point-of-care ultrasound in predicting fluid response?
Yeah, the question was particularly on the vasoplasia as part of the sepsis, or the opposite of this when we use the vasopressors, the effect of vasopressors or vasoplasia on the IVC. Of course, these are two of the pitfalls of use the assessment of IVC by point-of-care ultrasound. But at the end of the day, you should use everything as puzzles. If you know your patient is severely shocked, hypotensive, vasoplegic, so the systemic vascular resistance is very high, there will be redundance of vessels. And one of the vessels which will be redundant is the IVC. You're going to see the IVC may be dilated. And the opposite is when you use vasoconstrictors does not constrict only the arteries, but it does constrict in a less extent the venous system as well. So both of them have to be in mind when you see the collapsibility or distensibility indices for the IVC. You know your patient, you know what's going on, you know other parameters of the evidence of hypovolemia/vasoplegia. On the other hand, you know the other parameters from the point-of-care ultrasound that reflects that your patient is volume repleted or loaded or depleted. So you do not forget to focus on one organ, but focus on many. And a golden rule in point-of-care ultrasonography, one of the golden rules, is that you never stop at one finding. When you see the IVC, confirm what you're seeing with looking at the RV, looking at the tricuspid valve, looking at the LV as well. So it's a context of many things together.
Yes, exactly. And we have another question asking about other sites for measuring VTI instead of the LVOT, the carotid.
This doctor is asking about the carotid and femoral.
Yeah,
there are some data on this. Bottom line, for VTI, either you go with the VTI, which is area under the triangle or curve, or you go with a velocity time integral peak velocity, the peak velocity, or you go with the carotid Doppler or femoral velocity. The bottom line, another golden rule is that you have to know how to do it rightly. Otherwise, the yielding of the exam is going to be misleading, deceiving. We see, unfortunately, a lot of studies, by the way, published in big journals. And the researchers are putting pictures and they are using bad signals and they're doing wrong measurement and they conclude from the studies. When you do the VTI or peak velocity, you know where to put the pulsed wave Doppler, where to put it. And not only that, but also sometimes you cannot use the pulsed wave Doppler if you have a tricuspid regurgitation. You cannot rely on measurement when you have valve pathology, significant valve pathologies. There are a lot of things before you decide and take the measurement. You can go and do them rightly. So you have to study, to learn how to do it and how to apply it. Yes, there are evidence on the carotid, on the femoral, but not famously used as the LVOT VTI, either VTI as area under the curve or the peak velocities.
And this leads us to the, you can say, the gold statement. One of the questions is asking about what is the gold standard or what is the best parameter to use for assessing fluid responsiveness?
Great. This is a good question. And it differs between the spontaneously breathing patients and mechanically ventilated patients. And let me simplify it. The debate, which is very hot debate, comparing between invasive, the thermotechnologies, the thermodilution technology, versus the non-invasive, which is the transthoracic echo / transesophageal echo in detecting the fluid responsive, predicting the fluid responsiveness. There is big advantage of the thermodilution technology and Swan-Ganz, of course, that it's continuous. And the human error factor is, some people, they say, much minimized compared with the transthoracic echo. I would say this is not true. Because all of these machines, at the end of the day, it gives you a number. The beauty of transthoracic echo or point-of-care ultrasonography in general, that it doesn't give you a number, but it gives you physiology and anatomy. I see the heart and I can comment on the heart. The best way of predicting the fluid responsiveness when you do the point-of-care ultrasound is to respect the history and clinical examination and put the probe and see how is the heart and great vessel are behaving. There is no at all fallacy or doubt when the circulation, how it looks like when the circulation is empty. By point of care ultrasound, you and me and anyone can know by eyeballing that this circulation needs fluid and respond to fluid, and this does not. And the gray area and gray zone might need prediction of response. You do this prediction of response in a spontaneously breathing patient. The best way is to go with IVC. If your patient is not in labor to breathe and not with abdominal catastrophe, these two main hindrance. In mechanically ventilated patients, if you want to go with IVC exam, go with the distensibility, not collapsibility, and you go with the peak velocity without going and lineating precisely and accurately the curve, the triangle of the ejection of the systole that appears in pulsed wave Doppler. Without going with this, just go with the peak velocity. Keep in mind, as Xavier mentioned, respect the physiologic respiratory phase. Where are you? Where is your patient? Is he or she in inspiration or expiration? And see the variation, the difference between the behavior of the VTI during inspiration as compared to during expiration. Respecting also again, if your patient is spontaneously breathing or mechanically ventilated. The application of positive end expiratory pause of 15 seconds was found to be very, very practical and easy. Just to hold as you do with end inspiratory to measure the plateau pressure. Do it while you are measuring the VTI peak velocity. Very easy. Just put the probe on the apical 5 chambers, select the probe site, the Doppler site, fire it, and go ahead and measure the peak velocity while taking care of where is this cycle of VTI. Is it during inspiration or during expiration? People, they forget this point. We're gonna put maybe 1 or 2 weeks in the fellowship for details of this measurement concerns.
Yes, inshallah. And again, it's depend about the familiarity, availability, invasiveness, and non-invasiveness. All tools are working together to get a decision about the patient. About one last questions for me to you, Dr. Abbasi, directly, as we have that discussion with one of my friends regarding the use of point of care in pulse check and in detecting cardiac activity during traumatic or even non-traumatic cardiac arrest. Do you see that is going to be recently changing the game and to be integrated in the formerly ACLS or other guidelines algorithm about the using of point of care for both this differentiating BEA and pseudo BEA, and then again for the management it will be different?
Yes, of course. So that systematic review and meta-analysis done by Prof. Tim Harris and Steve Thomas, they manage many studies. And the problem with those studies, that some of the studies, there was some variability in training among the users. So if you have an expert user who can put the probe without uh, I would say minimal interruption to the CPR, like go sub-Z for it, get your view, and while pausing the CPR, it shouldn't take less than, I would say, 5 seconds. You don't need 10 seconds even. If you want, you can put the probe, get the view, and put a 5 seconds or 10 seconds loop. Then you can review it later when you assume the CPR. In this way, you minimize the interruption, you check for any like reversible causes, you check for the activity. As I mentioned, it's and that debate was going among some of our physicians too, how you diagnose this cardiac activity. Is the cardiac activity really only like flickering? Is it or you should get LV good contraction, aortic valve is opening or no? It needs to be unified. It needs to, for all users, they should have the same at least level of training, familiarity with the point of care use to diagnose such things. And the team leader, this is another point mentioned on this paper. The team leader, is the team leader know ultrasound and can take a decisions based on those findings, or he gets the message from the point of care user that this patient doesn't have cardiac activity. So me and you in the same room doing the resuscitation and examining the heart, we might have different opinion. I can see it.
Yeah.
It's meaningful cardiac activity. Some people may not agree with me. It's that could be one. Some physicians might want to continue chest compression. Some physicians, no, I will stop now. I can see organized activity despite I'm not feeling pulse. So this way, I'm going to start the patient on inotrope or support circulation with Levofed instead of continuing chest compression, because I can see the heart is pumping, although I don't feel any pulse. If you are not sure, put the probe on the carotid femoral, check if there is any good activity, even if you are not feeling the pulse. So I think it might change the management, but it needs time, more studies to be done in this field.
Thank you very much, Dr. Abbasi. You answered more than enough. Thank you very much. I think, Dr. Muhammad Nasr, we have to conclude here. Do you agree with me? So,
Yes.
again, thank you very much for the eminent speakers, Dr. Muhammad Abbasi and Dr. Xavier Monet. And a great thank goes to Dr. Muhammad Nasruddin for co-sharing this session. And of course, we missed Dr. Michelle Slama, who sent you the apologies because they have a difficult situation, meetings and different things in Paris this night, as well as Xavier Monet. Thank you very much for the whole attendees. We had tonight 470 plus attendees, and this is reflects how respect we have from the point of care fans. Thank you very much again. And the record of this webinar will be available in the next 24 hours, and we send to you in the groups. Certificate of attendance will be sent to your email very soon, within a few days. Thank you very much. And this is the last webinar before we launch the Point of Care Ultrasound online fellowship program. And we are very excited to meet all of you there. Thank you very much and have a nice night. Assalamu alaikum.